Hi, everybody.
Tell them about yourself.
Well, I will. I'll start here. I'll start here and then we can meet me, I guess. So we're talking about cannabinoid hyperemesis syndrome, CHS. And by no means am I an addiction specialist. I am a nurse practitioner in the emergency department at Winchester. I see this fairly often. We see this fairly often. And so I've taken what we have in modern research together with my experience in the emergency department, and I put those two together and made a presentation that I hope to sort of spread to the community, because this is a rising syndrome that we're seeing in the community. So what we're going to do today, introductions, talk about how we got here, legalization, what is cannabinoid hyperemesis, how did we make the jump from medical to recreational to seeing this on a fairly frequent basis in the emergency department, and then how do we treat it? How do we recognize it in the community? What do we do about it? So, like I said, I'm a board-certified nurse practitioner. I'm board-certified in both pediatrics and adults, and I work in emergency medicine. I work at the lovely Winchester Hospital. I've been there since 2017. I live there. I've taken care of lots of, I feel like I've taken care of the tri-state area now. We have lots of fun there. That's me in a body bag. And then I owe my life to Winchester. I met my husband there. And we have a lot of fun. So that's a little bit about me. So I talked a little bit about our goals, sort of understanding how we got from medicalization to recreational use to the syndrome that we're talking about today, how we're treating it, how we're identifying it, what we're doing about it, and then maybe fielding some answers. So I thought the best way to do that is to take you all to work with me. So we're going to meet our patient, Troy. Troy is in bed 1. He's coming in, he's clutching a vomit bag, he's complaining of terrible abdominal pain, he's retching loudly, vomiting. He said he's been sick for a few weeks. It's been much worse today. He's had a little bit of a workup for this. He's seen his primary care, he's seen a gastroenterologist. He's done all of the steps to sort of rule out other things. And he said, gosh, I've never felt this sick. Oh, and by the way, I do smoke marijuana on a daily basis, and I smoke a lot of it. I'm smoking multiple joints a day, and that's, it's never been a problem for me in the past. And so to understand how we got here, or how Troy got here, we have to sort of understand where we started. And so that was legalization for medical use, and that actually happened almost 30 years ago in '96. Over the last 10 years, the explosion of recreational use has far outweighed the medical use, and now it has become this cash cow, billion-dollar industry with levels of potency that have not been explored in recent past. So you can sort of see here on a timeline where things started. The circles are ballot initiatives, and then the squares are legalized versus the legislature, which obviously takes a lot more time. You can see most of these are medical use until about 2012, where Colorado and Washington legalized recreational use via ballot initiative, and then good old Massachusetts in 2016 legalized recreational use via ballot initiative. And you can sort of see the spiral after that, lots more states. What couldn't keep up is regulation during that time. Things sort of spiraled out of control. People saw an opportunity to make a lot of money, and with that, the potency of the products grew as well. And so right after legalization happened in Massachusetts, the NIH did a big study and asked sort of what people's pulse was on the fear of marijuana, the perceived danger of marijuana. Lots of people thought it was still pretty harmful. Alcohol and tobacco, though, far outweighed what people thought was a bit more harmful, life-threatening, that sort of thing. So people sort of thought it was still pretty safe. And with that, the use started to grow. And so you can see in '92, I think 1% of the people surveyed used marijuana, and that's because it was legal almost nowhere. And then 2022, 30 years later, we see this huge spike in marijuana, and we see a spike in alcohol too, but marijuana supersedes use of alcohol, largely use and then decreased perceive of harm. Alcohol is perceived as more harmful and largely is more harmful in many ways. And then with that spike of use comes a spike of daily use. So from almost 0 to 5% of people using on a daily basis, and then lots of people using at least once a year. Is there a risk? Can you die from smoking weed? The short answer is no. You can't really die from smoking marijuana, but what we did see over many years of time is that co-ingestion deaths were very prevalent, meaning when they did the plasma toxicology for these folks who have died, they also had marijuana in their system. So people who are using drugs that can kill you, fentanyl, cocaine, that sort of thing, they're also using marijuana. So it's growing in lots of different populations. Now, you can sort of see we almost saw no cannabinoid hyperemesis in the early 2000s and then a big spike. And that most likely is due to the potency of the products that have been produced. With recreational use, like I said, people were sort of rushing to make the most potent product. People who grow and cultivate these plants were leaving out the CBD and really potentiating the THC. So you can see 212% increase in THC content in the flower that's cultivated. And with that, people grow a resistance or a tolerance to these products and use more and more of them, and sort of that is reflected in what we're seeing with the elevated cannabinoid hyperemesis syndrome cases. So you can sort of see CBD is that bottom blue line, very stagnant. Those are all the flower products. And then the rise of THC in these products. You'll see there's a little dip in 2020. That's because they weren't really able to grow in 2020. But things are on the rise again. I'd be interested to see what the last 3 years, this is only till 2022, but I'd be interested to see what the last 3 years have shown. But the concentrations, as you can see, are sky high. Now, who are these people? Who are we seeing? Mostly it's young people. Men tend to outweigh women in terms of percentage. We're seeing lots more men who are coming back to the emergency departments multiple times. This particular study was about 70 to 27% men versus female. And they're using heavily, they're using frequently, which is something to remember. Now, what does cannabinoid hyperemesis look like? It looks a lot like the patient Troy. They're nauseated, they're vomiting. Things seem to be a little bit worse in the morning. They have diffuse abdominal pain. Sometimes they say it's sort of like sitting in their upper belly or their belly button, but it's really fairly diffuse when I'm seeing them. And then what I think is really interesting and a hallmark of this is that they're feeling better when they're showering and bathing. Something about the hot water on the body decreases the nausea receptors, so they actually feel a little bit better, and so they're taking multiple showers a day. They're soaking in a bathtub. They're losing weight. They're not eating and drinking. They're very dehydrated when I'm seeing them. And this can happen on a cycle, days to weeks to months. Some people may be thinking, don't we use THC to treat nausea and vomiting? Why would it be causing this cyclic syndrome? Well, the answer is not super easy, but we have two CB receptors in the body. One cannabinoid receptor in the brain and one in the belly. The one in the brain is sort of turned on with infrequent users, people who are cancer patients that are taking THC before their treatments to decrease their nausea, people who are infrequently enjoying with family and friends or privately. And when that is turned on, nausea and vomiting is decreased, and that's most infrequent users of marijuana. Now, CB2 lives in the stomach, and when you have repeated, frequent, high doses of marijuana, the case is flipped. CB1 turns off, CB2 is activated, and that causes the opposite effect. People are uncomfortable, they're nauseated, they're vomiting, and that's a hard cycle to break once this is activated. There are three sort of phases to cannabinoid hyperemesis. Prodromal, meaning it's not quite at the level that they're vomiting, but they're starting to not feel well. They're nauseated, they're feeling some abdominal discomfort. It's starting early in the morning. Hyperemetic means like a lot of vomiting. They have these ongoing cyclic bouts of nausea and vomiting. They're not eating and drinking. They're losing weight. They're very dehydrated. And then recovery happens basically when cannabis use is stopped. And it takes about 10 days for that to start to feel better. But if you continue to use, the risk is there. it is not certain that people will continue to have this cyclic nausea and vomiting. It's sort of random when the receptors turn on and off, but people who have a history of cannabinoid hyperemesis tend to get the condition again, and we see them over and over again as a result. In the meantime, we've not treated Troy yet, and he's very uncomfortable, so we'll start treating him. Yes?
I have a question. How long can't the first phase last?
Months.
Years, months?
Yeah,
years?
months, up to 2 years, really. People can feel sort of ill and then have their hyperemetic phase, which doesn't last very long for some people. Some people don't go to the hospital because they sort of get over it on their own, or they feel so sick that they stop smoking on their own, and then the cycle continues. They feel a little bit nauseated, they feel crampy, and they sort of get over it on their own. So yes, it can last weeks to months, up to 2 years.
And do you have any treatment when they are brought to the hospital? Like, what's the protocol for that?
I will tell you. Let's treat Troy. Troy's still feeling really lousy, so let's treat Troy. Well, first, let's diagnose Troy. So what are we going to do if somebody is brought to the hospital who's displaying these symptoms? My job is to rule out big, bad, ugly things, and it's also to rule out everything else, right? Cannabinoid hyperemesis syndrome is really a diagnosis of exclusion, meaning I've ruled out he has appendicitis or something wrong with his gallbladder or inflammation of the stomach lining. We've ruled out all of those things. We've ruled out a heart condition. We've ruled out co-ingestion with other drugs. So we're going to get blood. We're going to get urine. I may get some abdominal imaging. Usually when I'm seeing these people, they're sort of tender all over. It's hard to tell. And so Troy's already had all of the abdominal imaging. I've seen him a few times. He's back in the hospital. He's seen a gastroenterologist. He's had an endoscopy. He's had a colonoscopy. Those have all been clear. And that's the important thing. The workup is normal for other causes. And then adequate history. We know he smokes a lot of marijuana. And we know he's smoking high doses of marijuana. And so to diagnose Troy, we're going to use the Rome-4 criteria. So this is sort of like the best we got in terms of diagnostic criteria in the emergency department. It's fairly limited, meaning that not a bunch of research has been done. It's not super specific, and it doesn't say how many episodes of vomiting you absolutely need to have, how long it needs to be going on for. It's sort of limited in use. I won't say that we use it every single day in the emergency department, but people in addiction medicine, this is sort of the best thing that we've found meets the most needs of the patient. And so they've been symptomatic for at least 6 months. Nausea and vomiting the prodromal phase can happen for months and months. And so people oftentimes say, yeah, you know what, I have felt a little ill for the last several months, but I haven't been vomiting like this. And so it needs to be going on for a while. They need to have high dose use, at least over 6 months, and then lots and lots of vomiting. Lots and lots of vomiting. I cannot underplay the vomiting. And then the pathologic bathing behavior. Not everybody does it, but when somebody says that that's happening, that should raise a red flag. What are we going to do to treat it? Topical capsaicin, which is the active ingredient in hot peppers, actually comes in a formulation that we can use topically. And so with gloves, we rub it on the gloves and then rub it on the patient's abdomen. Unfortunately, we don't have it at Winchester Hospital, but it can be used in many applications and is actually available to buy. And so some people at home can use this. Now, it takes about 20 minutes to work and works up to 2 hours. So it's something you need to reapply, especially someone that's in that cyclic phase and continuing to vomit. But I'll go into what we normally use, which is haloperidol. Does anyone recognize this drug? This is an antipsychotic drug, and it is off-labelly used to treat cannabinoid hyperemesis. We start with little half doses and we titrate up based upon how the patient is feeling and what their weight is. Sometimes we use Benadryl because haloperidol can sort of make you feel wacky and it's quite sedating. So sometimes people find some benefit from using Benadryl alongside it. Lorazepam, anyone recognize that drug? Much more recognizable. It's an anxiolytic or an anxiety medicine. Also a great medicine used for nausea and vomiting, and it does not prolong the EKG interval. There's an interval in the conductivity of your heart, that we sometimes can't use haloperidol for. And so this is a good second line or an adjunct medicine that we use to haloperidol to decrease nausea and vomiting. And honestly, the goal when I'm seeing people in the hospital is to let them nap, because if you break their cycle and let them sleep, they will sort of come out of it, feel okay to eat and drink something, and be able to go home after they've slept. So we are decreasing that nausea threshold by also sort of sedating them. And then they're dehydrated when I'm seeing them, and they're dehydrated before they get to me. So we're giving them IV fluid. If their potassium, magnesium, or electrolytes are off, I'm repleting those when I'm seeing them. And then this is sort of what we talked about. Someone comes in, we maybe will give haloperidol, plus or minus capsaicin if we have it, and then maybe some lorazepam, maybe some Benadryl. And then on Danzatron is Zofran, which is a more common nausea medicine, also prolongs that EKG interval, so we have to sort of be careful when we use it. But most of the time, these cannabinoid folks are not finding relief when we're giving them Zofran, or they have it prescribed at home and they haven't found any relief when using it at home. And he's feeling much better. We've done our job. So we've talked about the hospital setting, we've talked about what I see, what I'm doing, but what can you all do in the community, and how can you recognize it? It's usually going to be your teens and your early 20s folks, young adults that we're seeing it in, so kids of kids, neighbors. What you're looking for is sort of someone who's using a lot of marijuana, someone who's using daily or near daily marijuana. You can use a minimum of weekly, but the folks that I'm seeing are using daily marijuana for the most part. They're losing a lot of weight. They've had this like on and off, undiagnosed abdominal discomfort, cyclic nausea, cyclic vomiting. They're seemingly going to the bathroom fairly normally, and they're feeling a lot better when they're showering. What should you do? Like if this is a neighbor or a child or whoever, for a good first stop is the primary care. Primary care is always a good first stop because they're going to start working up things that are not cannabinoid hyperemesis. They're going to start excluding all of those other things. So they'll start with blood work and all the things that we do in the emergency department. The next stop, if things are ongoing for some time, a gastroenterologist may be helpful in doing a direct visualization of the areas, the upper and lower bowel. And then last stop, the emergency department. When it's an emergency, they're vomiting so much, they're not producing urine, they can't keep anything down, they're in severe pain. They need to come see us. Some people, well, a lot of people that I see, it's not the marijuana, it can't be the marijuana. I've never had a problem with this before. I don't want to go to the hospital. What can they do? They can take a hot bath or a hot shower. They need to hydrate in between those vomiting episodes. So either in the shower or right after when they're feeling better, they need to excessively hydrate. So there is some research about cognitive behavioral therapy in terms of talk therapy, decreasing use of marijuana, and also like essentially meditating before they vomit to help stop that cycle. And then the only known cure for this is to stop smoking marijuana and stop all ingestion. It takes about 10 days, but can take a few weeks to really start to work. So they don't feel better right away, and sometimes that's discouraging. They continue to use, and then we are sort of back in the same cycle. But really the only thing that stops this syndrome from reoccurring is the cessation of cannabis use. And so that's sort of what you can do from home if they don't feel super inclined to come to the hospital or the medical setting. And that is cannabinoid hyperemesis. Thank you. Thanks for coming.